Hello students, welcome back to BSN 720, Shock and Multi-System Organ Failure. So the two terms you're going to hear about throughout this class is shock, and another term is multi-organ dysfunction syndrome. And the short form is MODS, M-O-D-S, which stands for multiple organ dysfunction syndrome. Or you will hear different terms for this like multi-system failure, multi-organ failure. Anyway, the result is inevitable as a death of a patient, but that's what the end result of shock will be if not treated. So we're going to learn about shock, sepsis, and multi-organ dysfunction syndrome. Shock simply means it's characterized by decreased tissue perfusion and impaired cellular metabolism. So we need oxygen for the cells to survive or thrive. When there is lack of oxygen or decreased tissue perfusion, there is ischemia to that organ and cellular death will happen. Before that, there is changes in metabolism. You'll see that there is anaerobic metabolism happening in the cells. I want you to keep this in mind. The cardiac output is determined by the heart rate and the stroke volume. And stroke volume is usually determined by the preload, afterload, and the contractibility of heart. So stroke volume basically depends on the blood flow to the heart and the contractibility of the heart. Let's see what shock means. So as I said before, there's decreased tissue perfusion and impaired cellular metabolism, which results in lack of oxygen to an organ, which leads to ischemia, which leads to cellular death or injury. And that becomes life-threatening at that point. Simply put, there is an imbalance between supply of oxygen and demand of oxygen. Or in other words, you can say that shock could happen in two different ways, either because of lack of blood flow or low volume of blood, or as a result of maldistribution of the blood. So in low blood volume, that's usually because of cardiac origin or hypovolemia as a result of a trauma or like bleeding into the system or something like that, or simply put, it could be severe vomiting or diarrhea. Maldistribution is the result of mostly there is a difference in the tone. So there is any neurogenic problems or anaphylactic shock or septic shock. That was the last one. All of this could lead to maldistribution of blood flow. We'll see each of them in detail, so not to worry about it. We can classify shock into we have three different types here, but you can also see obstructive shock. That's also a category of shock. So basically, hypovolemic is hemorrhage, burns. We learned about burns in the previous class, dehydration. All of this can lead to hypovolemic shock. Then cardiogenic shock, usually something related to the heart, like a severe acute MI, cardiac tamponade. That means there is fluid or blood collection around the heart, so heart cannot contract. We said it, the stroke volume is affected by either the preload, the volume of blood in circulation, the afterload, the pumping of the heart, or it could be as a result of the contractibility of the heart. So cardiomyopathies are conditions of the heart muscles that it's hypertrophied and it cannot function properly. All of this will contribute to the cardiogenic type of shock. And then distributive shock is usually neurogenic shock, where the sympathetic nervous system, which maintains the vasomotor center, or that sympathetic nervous system is affected. It could affect the distribution. Septic shock, in case of release of toxins, it can affect. Anaphylactic shock is like a type 1 hypersensitivity reaction. We'll learn about all of this, so not to worry. So first type, low blood flow type, which is cardiogenic, and a hypovolemic type, and of which we're going to look at the cardiogenic shock. So cardiogenic shock is usually caused by a disease condition of the heart. It could be something which is affecting the right side of the heart, or it could be the left side of the heart. Cardiogenic shock has got high mortality rate. 50% mortality rate happens in cardiogenic shock is caused by myocardial infarction. So cardiogenic shock is very serious. It could cause high mortality in the patients. So conditions, as we said before, I'm going to say something different from this. So systolic dysfunction can cause cardiogenic shock. Diastolic dysfunction can cause cardiogenic shock. Systolic dysfunction is the heart's ability or inability to pump enough blood. Diastolic disability or diastolic dysfunction is usually related to the filling of the heart. So any like conditions like mitral regurgitation or like uh, any of those regurgitation, blood flow backward, so it doesn't fill the ventricles adequately to pump enough blood out. Those kind of dysfunction is called diastolic dysfunction. Um, so as a result of inadequate volume or filling is the diastolic dysfunction. Inability of the heart to pump blood out is the systolic dysfunction. So these are the causes for cardiogenic shock. Then myocardial infarction can cause this, cardiomyopathies can cause it, severe pulmonary hypertension can cause it, any injury to the heart can also cause this, and in severe case of sepsis also, it can cause severe myocardial dysfunction. So what happens in cardiogenic shock is patients will have early manifestations like tachycardia and tachypnea. This is as a result of our body trying to compensate. So it usually manifests as like a heart failure. There is hypotension and tachycardia. Whenever there is low blood pressure or sympathetic nervous system gets stimulated, that means you might have learned about the baroreceptors and the chemoreceptors in the aortic arch, right? So it sends signal to that whenever there is low blood pressure, in order to compensate, the sympathetic nervous system is stimulated. It causes tachycardia, tachypnea, all of those symptoms. One of the classic feature of shock is narrowing of pulse pressure. So to recollect, previously when we learned about head injuries, you learned about increased intracranial pressure. In that you learned there is widening of pulse pressure. Pulse pressure is the difference between systolic and the diastolic blood pressure. So on an average, normally, it should be 120 minus 80, that is 40 millimeters of mercury. So widening of pulse pressure happens with increase in intracranial pressure. Narrowing of pulse pressure happens with sepsis and shock. And this is very classic. If you see a person's blood pressure dropping, like it was 80 or let's say 100 over 60, then it dropped to 80 over 50, and then the drop kind of the systolic drop will happen, also diastolic will happen, but the pulse pressure between that will drop to 30, 20, etc. If you see that drop, that's really high risk. That is very alarming. You have to act right away because that is a classic feature of shock. Now, later, as a result of cardiogenic shock, you will see that the patient has like hypoperfusion symptoms like decrease peripheral pulse or cyanosis, pallor, diaphoresis, cool and clammy skin, delayed capillary refill. All of these are later signs of cardiogenic shock. So these are the features you will see. Initially, you'll see hypotension, tachycardia happening. Then eventually patient's pulse pressure is narrowing. And then you also see other signs of hypoperfusion. And one of the classic features of peripheral hypoperfusion is decreased urinary blood flow, and which eventually causes decreased urinary output. That's why people who are working in ICU settings, it's really, really important that we check the hourly urine output, because that's a great indicator of a patient's progress or how this patient is going to progress. In the earlier stage, you will see the patient has impaired cerebral blood flow. So one of the classic features of that is agitation, aggression, confusion. All of those symptoms are seen with decreased cerebral blood flow. So sometimes, before patients go into all the other symptoms, they might just become delirious, or they might appear confused. So that's why it's important that we assess the confusion, confusion assessment, and make sure that they're not delirious, because those are all like early warning signs which we can see. Eventually, if not resolved, this will lead to the multi-organ dysfunction syndrome, or MODS. Now, that is about cardiogenic shock. In hypovolemic shock, there is low volume of blood in the system. So this could be as a result of absolute hypovolemia, which means there is hemorrhage, or a patient has severe diarrhea, vomiting, one of those symptoms, or they have diabetes insipidus where they lose volume, or we used excessive diuretics. So any of this can lead to hypovolemic shock. That is our absolute causes. We can also have relative causes, because we learned in case of burns, remember we said because of the capillary permeability is impaired, the fluid will shift into the third space. So those are called relative hypovolemia. There is no real hypovolemia. It's just the fluid is moved from one compartment to the other, or third spacing happens, or sometimes we loses blood or volume. So it could be either or. Then other things about, sorry, I missed a slide, but I can't go back in this. So what I was going to say is, so initially, what that slide has is, when we have like about 15% of fluid loss, our body can compensate itself. That's 15% blood loss or volume loss, means we have lost about 750 mLs of blood or fluid from the body. That if that happens, the body compensate. You might not have severe signs and symptoms or anything, but 15 to 30% patients will have manifestations. About 30% is very serious. So that causes severe symptoms in patients, and eventually, if not compensated or not treated, it will lead to multi-organ failure. So what happens in hypovolemic shock is, either there is the vascular compartment is never changed. The capillary permeability changes, so the fluid would leak into the surrounding tissue, or sometimes patients would just lose the volume. Anyway, all of this lead to decreased preload. There is less volume of blood in the capillary system or the blood vessels, which lead to decreased preload, which leads to impaired cellular metabolism because there is not enough perfusion. So our cardiac output and the cellular perfusion are affected as a result of hypovolemic shock. Now, again, all the signs and symptoms depends on age and other factors. So infants, they have more fluid volume in their system. Then for older people also, they might manifest the symptoms of volume loss really earlier than a person who is middle-aged. And the extent of the injury, their underlying health status, all of this can affect the severity of hypovolemic shock. Simply put, what happens in hypovolemic shock is our cells are not perfused properly. So cells will undergo anaerobic metabolism. So you'll see that there is more anaerobic waste products like lactic acid accumulated in the body. That is an early indication of hypovolemia or anaerobic metabolism. Our priority is to replace fluid volume immediately. So it could be either crystalloids or colloids. Crystalloids means are solutions like normosaline, Ringer's lactate, etc. Colloids are like albumin in blood products. And mind that we have like 5% and 25% albumin available. And the best practice recommendation is to use 25% albumin. 5% is like old school practice. This is as per the recommendation of the OrbCon or Ontario Blood Bank. I don't remember the expansion of OrbCon, but they decided that, or they bring in the evidence-based practice and the latest practices. So nowadays they say that don't use that 5% unless we are treating hypovolemic shock. So sometimes in hypovolemic shock, we might use the 5%. That might be the only case we use it, but most of the other treatment with albumin, you use the 25% product. Now, control bleeding, reduction of fluid loss, discontinue thrombolytics and anticoagulants. So what that means is that this is just to discontinue the therapeutic dose of the thrombolytics or anticoagulants. We still would give the patient DVT prophylaxis. So if we are using therapeutic dose of anticoagulation like enoxaparin or something treated used to treat a clot, you would be like giving 80,000 unit, but your prophylactic dose of dalteparin or one of those medications would be like 5,000 units. So see the difference in the dose, 5,000 and 80,000. 80,000 is your therapeutic dose, 5,000 is your DVT prophylactic dose. So that's very low dose compared to the therapeutic dose. So that's important. And then we'll see the management in general at a later time, but we always make sure that ABCs are given importance and also treat any cardiac arrhythmias. Best positioning for patients who are experiencing hypovolemic shock is supine position with bed of the bed elevated, the lower part of the bed elevated or the foot of the bed elevated so that there is more venous return to the heart. So a little bit about blood transfusion. We're going to learn next week in detail about blood transfusions, but still I just want to reinforce the fact that blood is always checked by 2 nurses prior to administration. Administered within 4 hours. That means the time of dispatch from the blood bank to the administration time. We don't want it to sit outside for longer, because if you're not infusing the blood in the first 20 to 30 minutes of arrival, you're not ready to infuse or something, you should return it to the blood bank. And we always hang it with normal saline. Do not use dextrose. Even though we learned that dextrose is an isotonic solution, dextrose usually disintegrates into a hypotonic solution as soon as it gets into the body. So it's not isotonic after administration. You're not supposed to add anything to the bloodline. So if you're administering blood, you will have to use one line exclusively just for the blood. Another thing is that for that reason, you will see for the management of shock, you're asked to put in 2 large bore needles as soon as you find that the patient is collapsing, because you need a second line, because if you're using the one line for blood transfusion or something like that, you cannot use that to administer your medications. Ideally, you should stay with the patient for the first 15 minutes. That is the best practice. A lot of times on floors and on units, you would see that nurses will hang the blood, set up their timer, go out and check their vitals after 15 minutes. But ideally, if anyone asks you, you should be monitoring the patient closely for the first 15 minutes. And that's when most of the reactions happens. And we'll learn in more detail about the blood transfusion and the reactions. But if you see that the patient is reacting, if you see the patient is reacting to any medication or anything, immediate first response is to stop the infusion. Okay, not calling the MD or not notifying anyone. For you have to take certain actions, and your actions will be, to stop the infusion. run another line of normal saline. Do not use the line you were running the blood. You discard it. You're not going to use that line. You're going to use a new line with normal saline infusion. Check vital signs, then notify the MD and notify the blood bank. So those are your sequence of actions in case of hypovolemic shock and if you're doing blood transfusions. Now, next category is the distribution type of shock, and the first one is the neurogenic shock. So you usually are going to encounter patient with neurogenic shock most likely in spinal cord injuries. That's the most common cause. This can happen within 30 minutes of injury to about 6 weeks. So neurogenic shock is because of the activation or the massive vasodilation caused by loss of sensation or the loss of sensation of the sympathetic nervous system. And the sympathetic nervous system is the one which sets our vasoconstriction tone. So we have lost that, and that is the reason for the neurogenic shock in patients with spinal cord injuries. Um, so it can be accompanied by fainting, maybe and by severe pain. A lot of things can trigger this neurogenic shock, but the commonest cause is spinal cord injury, especially injury at T5 or above. This can also be caused by spinal block anesthesia. So giving spinal block anesthesia, we block the sympathetic nervous system. So the vasomotor or the vasoconstrictor tone is gone. It causes a massive vasodilation. So as a nurse, our responsibility is to look for these symptoms for a patient who has got a spinal block. That's why we monitor them closely after spinal block or severe pain. Any of this or any injury to the medulla of the brain, which is a vasomotor center. So any injury to that can also cause severe vasodilation. Certain medications like benzodiazepines, opioids, all of that act in the vasomotor center or the medulla of the brain, can cause neurogenic shock. So there are different reasons for that, but the commonest one is spinal cord injury. What happens in this type of shock is that, so all the other type of shock, what you're going to see is hypotension and then activation of the sympathetic nervous system, so tachycardia. This is the only type of shock where you see bradycardia with hypotension. So learn that really well. I might ask questions about that because all the other type of shock, how do we differentiate neurogenic shock? Because of hypotension and bradycardia. Other types you would see an increase in heart rate, and the reason you don't see the increase in heart rate is because of the that sympathetic nervous tone or the sympathetic nervous system is severed, so it doesn't have any action. We talked about this. It could happen 30 minutes after an injury and can last up to weeks. All that. Management is again fluid replacement and medication to maintain the blood pressure. So that is one other type of shock which we learned. And the next one is anaphylactic shock. What happens in anaphylactic shock is it's a hypersensitivity reaction or an allergic reaction in the body. So as soon as we get exposed to an allergen, which is an antigen, it's either a protein. So people who have like peanut allergy, they're allergic to the protein. People who have egg or beef allergy, all of them are allergic to that protein. So that is our antigen. As soon as it enters the body will release antibodies or IgE immunoglobulins. Those are the antibodies. They get attack the protein and they form an antigen antibody complex or an immune complex, which causes all the problems. This leads to release of chemical mediators, which causes vasodilation, which causes decreased tissue perfusion, which causes also cause like bronchospasm, edema of the upper airway. All of these symptoms are caused as a result of that immune reaction, which lead to sudden death. So this is very life-threatening condition. There is massive vasodilation. As I said, this chemical mediators are released, which also increases the capillary permeability. So there is third spacing sometimes, would also lead to like respiratory distress because there is angioedema, bronchospasm. All of this causes obstruction of the airway, and the patient could even go into something called ARDS, or acute respiratory distress syndrome. We'll learn about that later. But all of that can happen as a result of that release of immunoglobulin or IgE. And this also causes like anxiety, confusion. Patient would have like a feeling of impending doom. They feel like they're going to die. Laryngeal edema, bronchospasm. That is the biggest complication of this, because respiratory failure will lead to sudden respiratory arrest. Treatment, you will see that the patient will get epinephrine, or we know that people who have allergies, they carry their EpiPens. The dose usually is either 0.5 to 1 milligram, and it's administered every 3 to 5 minutes. So it could be given sub-Q or IM or IV, either or. Sub-Q and IM are like later or delayed action. IV is like immediate action. So in a code blue, you'll see that it's given IV, but if someone who's having an allergic reaction, they already know about it, might be given IM or sub-Q. And our biggest role here is to maintain a patent airway. Then we administer fluids, colloids or crystalloids. So you will see one of the good IV fluid which we can use in case of metabolic acidosis is Ringer's lactate, because it provides the bicarbonate ion, except in patients with liver failure, it's not recommended. So most of the cases you would see we use either normal saline or Ringer's lactate. Ringer's lactate is good because it can compensate for that metabolic acidosis or like that anaerobic metabolism which is happening in the body, except patients with liver failure. So just try to remember that. Now we give bronchodilators, antihistamines. In severe cases, patients might need vasopressor support, which we're going to learn in the management. Now, septic shock. So this is another kind of shock. It happens as a result of an inflammatory response to an infection. So it could be the causative organism could be gram-negative or positive bacteria, fungi, or like viruses, variety of organism which causes sepsis. It contains toxins. So these toxins are released into the bloodstream, which causes the release of cytokines or cellular response mediators, chemical mediators, which causes platelet aggregation or clumping of the platelets, neutrophils to line along the blood vessel, which causes like increase in capillary permeability. So a cascade of reactions happen as a result of this bacterial or the endotoxins released by the organism, which causes something called cytokine release syndrome. So that is what causes the increase in capillary permeability. As we know that, you might have heard about this, when we learned about when we learned about corona virus or COVID-19, it was not the virus itself which was causing the death of patients. It was the cytokine release syndrome, or that inflammatory response happening in the body was causing most of the problems or most of the complication which lead to the death of a patient. So presence of sepsis with hypotension despite fluid resuscitation is a bad sign. So you'll see that in patients with sepsis, even though we fluid resuscitate them, they're still in a hypotensive state. Their blood pressure is not improving. And that's really alarming. If you have a patient and you're fluid resuscitating them, they're not improving, their blood pressure is not improving, that means they might have a poor outcome. Now, as a result of this cytokine release syndrome, because of the neutrophils and the platelets and all of that lying together, it causes microthrombus in the circulation. So it further decreases the tissue perfusion. All of this vasodilation, impaired capillary permeability, microthrombi, all of this eventually lead to more and more anaerobic respiration in the body, which lead to formation of lactic acid. So one of the indicators of sepsis with shock is increase in lactic acid levels. So that's one of the blood tests we would do in that case. Also, if you are working in a ICU setting, you'll see that those urinary catheter bags will have urometers on it that you are supposed to measure the urine output very closely, and we want to make sure it's about 30 mLs per hour, which is an indication of good renal perfusion, which is another indication of that there is enough tissue perfusion. You'll notice that patients' neurologic status changes. Basically, they're more agitated and confused. So different type of shock and the changes you will see with the central venous pressure or the pulmonary catheter wedge pressure, that usually in cardiogenic shock this is increased, but rest of the cases it is decreased. Cardiac output, even though cardiac output is increased, the stroke wall, the systemic vascular resistance and all of that is reduced. So there is impaired perfusion, even though there is more cardiac output. Like I said before, even though we fluid resuscitate them, they're more hypotensive. That is a classic feature of septic shock. And you can look at the different characteristic of different type of shock. This is all we have already discussed. Now, relationship of shock, SIRS, and MODS. What happens in all this different kind of shock is eventually it leads to inflammatory mediators or responses, which lead to release of the cytokines, vasodilation, increased capillary permeability, third spacing or edema, and microthrombus in the circulation. So you'll see some of these features are common for most of the type of shock. And then it eventually affect all the target organs. So we're going to see the different stages of shock. Initially, uh, maybe you don't see any clinical features on these patients. They might have, like I said before, when there is hypovolemia, 15 percentage, about 750 ml fluid loss, our body compensate for it. You won't see any clinical features. But as the hypovolemia increases from 15 to 13 percentage, 30 percentage is when you would see the clinical features, and if it's more than 30 or 40 percentage, it is life threatening. So as I said initially, it might not be apparent, and then you will see the lactic acid levels are increasing. Whenever there is anaerobic metabolism, the waste product is lactic acid accumulation. Our body will go into metabolic acidosis. So you check the lactic acid levels, and if you see that it's increasing, that means the patient's condition is worsening. Uh, and it's usually detoxified by the liver. Then we go to the next stage, or the compensatory stage, where body itself tried to attempt to do homeostasis or maintain balance. The baroreceptors in the carotid and the aortic bodies will activate the sympathetic nervous system, and as a result, it helped to increase the blood pressure, and also it tried to increase the heart rate. So it increases the blood pressure by causing vasoconstriction in the vital organs, and then decrease blood flow to the kidneys. That's why you see a decreased urinary output. That's kind of alarming because the blood flow is decreasing. So that's the compensatory stage. And what the sympathetic nervous system does is it does a bunch of work. So initially, let's see if it's here. No. So initially, the sympathetic nervous system stimulation causes vasoconstriction, which also release vasoconstrictors like epinephrine and norepinephrine from our body to help with that is our flight or fight response, right? The sympathetic nervous system stimulation. That's why heart rate is increased and all that. And try to maintain the blood flow to the heart and the brain. It also decreased the blood flow to GI system, because that's kind of the low key organs. We're trying to save the blood for other vital organs. So that results in stress ulcers. So whenever a body has a risk to go into shock, they always develop stress ulcers. So it initially as paralytic ileus and then stress ulcers. Extremities will be cool and clammy because there is reduced blood supply. Shunting of blood from the lungs, which causes increase in the dead space in the lungs, and so that is why when patients are in metabolic acidosis, they have like labored breathing to compensate for that. So you'll see that the patient is tachypnic. A sympathetic nervous system stimulation also increases the heart rate. So patient is trying to recover from this. If not corrected, they'll go into so these are the clinical manifestation: increase in pulse and respiratory rate, decrease in urinary output, cool clammy skin, narrowing of pulse pressure. And these are all very alarming signs. You shouldn't let your patient go into that, but we try to fix at this stage. And if that is not happening, then the patient will progress into the progressive and the refractory stages. And then I don't the chances of recovery are very less. So this is when our body go into that multi-organ dysfunction syndrome, because there is not enough cellular perfusion, and more protein is leaked into the interstitial space, so the interstitial edema increases. As a result, blood pressure further decreases, and also because of the vasoconstriction, there is more hypoxia, more metabolic acidosis, more cellular death, more organ dysfunction. So then it kind of progresses into um, uh, progresses in such a way that there is no coming back. So patients again would have tachycardia, tachypnea, weak pulse, or maybe absent pulse. Urinary output continues to reduce, and then they progress into in the lungs. Also, there is impaired gas exchange. The ventilation perfusion ratio is altered. You could see there is congestion in the heart because of that third spacing. Again, it causes pulmonary edema. So it further decreases the breathing space or the air exchange space because of the pulmonary edema. The surfactants, which help with the movement of gas in between the capillary and the alveoli and the outer space, get all messed up, and there is not enough gas exchange happening. So it further decreases the respiratory system. So all the systems are now shutting down. In the myocardium, as a result of this, you would see ischemia, arrhythmias, and then failure. So in also in the progressive stage, because the liver is not functioning, there is not enough clearing of waste products. It results in elevated liver enzymes and loss of immune function. And remember, I said whenever there is liver failure, Ringer's lactate is not the best solution. Then we go with normal saline. If the patient has a functioning liver, there is no problem with liver function. We usually go with Ringer's lactate to help with the metabolic acidosis. So fluid resuscitation itself becomes very, you have to be very careful depending on the patient's condition. And then DICs, or disseminated intravascular coagulation, happens. So that means there is bleeding and clotting at the same time. And that's very dangerous, because if it's bleeding, we can stop or give something to stop the bleeding. If it's just clotting, then you can give clot busters to overcome the state. But when both of it happens at the same time, it becomes really tricky to treat. And then last stage is the refractory stage, where there is more and more accumulation of lactic acid, hypotension, tachycardia worsens, coronary blood flow also reduces. That means that all the organs are shut down eventually. So at this point, there is no coming back. Eventually, at the refractory stage, sympathetic nervous system is no longer functioning. Tissue hypoxia happens, and end result is cardiac or respiratory arrest and death. So this is a flow sheet which explains this in a decent way. So if there is hypovolemia or heart failure or vasodilation, all of this lead to decreased cardiac output, eventually lead to decreased tissue perfusion, which leads to hypoxia or cellular anoxia. Releases cytokines, which causes a whole bunch of inflammatory response, causes acidosis because of the anaerobic metabolism, also causes thrombosis and hemorrhage at the same time. So all of this again accounts for less tissue perfusion. Then renal failure happen. That's why it's important that we monitor the hourly urine output. Lung failure happens, or acute respiratory distress syndrome or collapse of the lung happen, respiratory failure happen, and in GI system there is decreased blood flow. So it causes ulcer, paralytic ileus. Other organs which are affected is brain, cerebral ischemia happens. So sometimes hypoxic brain injury happen as a result of this. And also, one of the other major organ is liver, which is involved, because liver does not have enough tissue perfusion. So the natural killer cells in the liver, or the Kupffer cells, which act against the bacteria, because GI system bacteria sometimes get into the liver, and the liver will clear it all up. So all those compensatory mechanism in the body, or all the normal physiologic functions, are altered. As a result, you would see there is more and more organ failure happening as the disease condition progresses. The diagnostic test we see in case of shock is just not any single study. So usually elevation of lactate at an earlier stage, if someone comes in septic and you check their lactate levels, it's elevated, that's kind of a bad sign. So we become more alarmed, and we try to look and see that the patient doesn't go into that refractory phase of the septic shock. ECG monitoring will show arrhythmias, X-rays will show pulmonary congestion, pulse oximetry will be always low. Hemodynamic monitoring is usually done with a central venous catheter. So all times when the patient is at risk for a septic shock, we're going to put in a central venous catheter. There are multiple reasons for it. One is to monitor the central venous pressure or the pulmonary artery wedge pressure. So these are the tests. Another thing I forgot to tell you was in septic shock, you will also see that even though patient is not diabetic, their blood sugar level will be elevated. So a patient who has temperature, not diabetic, with blood sugar more than 7.7, it's an indication that they might be going into septic shock. So make sure that you also look for that. And hyperglycemia is also a sign of septic shock. So that's another test we will do. Now, management is, we can say any management, any patient who is going to collapse, the management is ABC. Always check for airway, breathing, and circulation. And also identify the risk factors which can cause the shock. So patent airway, optimizing airflow. So oxygenation and ventilation has very significant role in a patient who is going into shock. Sometimes we might have to put in an endotracheal tube, optimize the oxygen delivery by 100% oxygen delivery. Also, maybe they need mechanical ventilation. So those are the things basically about airway and oxygenation and ventilation. If there is any volume loss, the management is blood transfusion. And then we monitor the pulmonary artery wedge pressure, which kind of gives us also a sign of the oxygen saturation. So if there is enough perfusion, there is enough saturation. Indwelling catheters are always used, and hourly urine output is monitored and make sure that it's about 30 mLs per hour. Always establish 2 large bore IVs because you will have medications which cannot be mixed, or if you're giving a blood transfusion, you cannot mix with that. So most of the times you will see that these patients would have an arterial line or a central venous catheter, a triple lumen or a double lumen central venous catheter, most likely a triple lumen catheter. And can you give a medication which is like incompatible through a central venous catheter? Answer is yes, because if you look at the blood flow, your hands, lower arm, probably will have 40 to 80 mLs of blood per minute. Okay, as it go up to your like subclavian artery, there is 800 mLs of blood moving in a minute. As it go to the superior vena cava, there is blood mixing 2 liters per minute, 2 liters of blood per minute. Because of that reason, you can give incompatible medications through the different lumens of a central line. You don't have to worry if it's compatible or not, because it mixes so fast, so it's not going to cause any reaction. So all of these patients who are going into shock or are admitted to intensive care unit, most of the patients or almost all of the patients will have a central venous catheter. And also some of the medications we're going to give are also can cause extravasation or tissue injury. So it's safer to be administered using a central venous catheter. So these are the reasons you will see that patients have central venous catheters. Then medications which are used in this case are vasoconstrictor medication or vasopressor medications are also used to maintain the blood pressure. These medications in general are called sympathomimetics. As we know, we have 2 nervous systems, sympathetic nervous system and parasympathetic nervous system. Sympathetic nervous system has alpha and beta receptors. And you know the medication beta blocker, what does it do? It helps to reduce the blood pressure by blocking the beta receptors. So sympathomimetic drugs which acts on the alpha and beta receptors in the body help to do vasoconstriction to maintain blood pressure in case of hypotension. That's how these medications work. Some of the medications are called inotropes, which increases the myocardial contractibility. Examples are dopamine and dobutamine. These are all precursors of epinephrine and norepinephrine. So it increases the heart rate, try to maintain the contractibility of the heart. Then epinephrine is a category of medication, beta adrenergic agonist medications that help with the vasoconstriction effect to increase the blood pressure. So beta antagonist is beta blocker. Beta agonist medication is to help with the vasodilation. Again, another category is alpha adrenergic agonist medication. Then we also use like steroids, a large dose of steroids. It's not usually recommended, but if you are not able to get the blood pressure high, sometimes you will see that hydrocortisone is used in that case. Vasopressors like vasopressin is another type of medication, which is an antidiuretic hormone that is also given. So these are the common medication. The vasopressor medication, so examples are dopamine, dobutamine, epinephrine, norepinephrine, your vasopressors, all of that help to increase the mean arterial pressure. So it is important that we maintain the mean arterial pressure at least 65 millimeters of mercury or above. That means there is enough tissue perfusion. So that is the reason we give all these vasopressor medication. And at least it should be above 65 millimeters of mercury. If it's going to be below that, that means the patient is not going to respond. Before moving on with the care, nursing care, I just want you to know how to calculate the mean arterial pressure. So mean arterial pressure is calculated with systolic blood pressure plus 2 times diastolic blood pressure divided by 3. So that's the formula to calculate mean arterial pressure. And normally, normal mean arterial pressure is about on an average, it's like kind of 90, or normal range is from 70 to 100. And if it's below 65, that's an indication, or below 60 is an indication of poor tissue perfusion. So that's why we wanted to maintain it above 65 millimeters of mercury. So that's how we, the formula is systolic blood pressure plus 2 times diastolic blood pressure divided by 3. And that's the formula to calculate it. So again, collaborative care, we're looking at indwelling Foley catheter with the urometer to check the hourly urine output, blood pressure, vasopressor agents, vasodilator therapy if indicated, enteral tube or NG tube in case if there is any GI bleed or something to identify that, or to prevent complication or bacterial dislocation, translocation to the liver. ABCs are always important, so nursing assessment, that's the priority. We're going to learn about prioritization of care too. Tissue perfusion, look at the mean arterial pressure, allergies, all of that. And these are some of the nursing interventions to look for. So all those patients would have blood pressure, heart rate, and their respiratory rate monitored at 15 minutes. So when it's impossible to do that, we put them on a continuous monitor where all of this is monitored, and also continuous cardiac monitor to look for arrhythmias. So I want you to go through and read about this